So you guys already know that skin is a first line of defense for our bodies. So skin is a barrier so that unwanted organisms can't get inside of our body. They have to go through the skin, that protective layer, in order to infect us. The skin, however, is commonly cut, sliced. We get paper cuts, we get more, you know, serious trauma to our skin, so that those cuts and things allows organisms to get into our body. So our skin is divided into 3 layers. You have your subcutaneous tissue layer, which is rich in fat. It has your hair follicles, your sweat glands, and there is a fascia, which is a barrier so that it's barricaded from those deep tissues in your organs. The dermis is very rich in blood and nerves. It has shorter hair follicles as well as sebaceous glands. The epidermis is your squamous epithelial cells. So here is a picture of the skin anatomy and where the different layers of the skin are. You can see on the right side, you can see the epidermis on the very top, then the dermis, and then the subcutaneous and fatty tissue. So you guys, again, already know the resident flora of the skin. So you know that our Diphtheroids, which is the Corynebacterium species, are common skin flora. And the species that's common is xerosis. So Corynebacterium in the clinical setting, they're all just called diphtheroids. We have our gram-positive cocci, such as Staphylococcus aureus, which is usually a transient colonizer. Sometimes you might be carrying it on the skin, and other times you may not. You have Streptococcus species, several different species that can reside on the skin. And you have your most common flora, which is the CNS or coagulase negative staph, especially Staphylococcus epidermidis. You may also have yeast, such as Candida albicans, as well as your anaerobe Propionibacterium acnes, which is one of the common causes of skin acne. So the different types of skin infections, you have macules, which are usually caused by viruses. You have papules, which are commonly caused by pox viruses, human papillomavirus, or Staphylococcus aureus. You have nodules, which can be caused by Staph aureus, Corynebacterium diphtherii, or nocardia. If you guys remember, nocardia is a gram-positive branching organism. You have pustules, which can be caused by Staphylococcus aureus, group A streptococcus, which is Streptococcus pyogenes, as well as herpes simplex virus. You have vesicles, which are more commonly caused by viruses such as your herpes simplex virus or herpes zoster virus. You have scales, which are caused again by group A streptococcus. Ulcers, which can be caused by Haemophilus ducreyi, Treponema pallidum, and Bacillus anthracis. And bulla, which is Staphylococcus aureus, group A streptococcus, and possibly some of your gram-negative rods. Hair follicle infections, or infection of the hair follicle, is a localized abscess. It can be folliculitis, where just the follicle itself, it gets infected and inflamed. You can get a furuncle or a carbuncle, which are like boils. So what happens is you get bacteria that gets embedded and blocked into the hair follicle, which leads to a localized infection. And Staphylococcus aureus is the most common agent that causes folliculitis. However, you can get hair follicle infections from other organisms, possibly some of your Enterobacteriaceae members, as well as Pseudomonas aeruginosa. but Staph aureus by far is one of the more common causes of folliculitis. Your epidermal and dermal infections. So you have erysipelas, which is caused by group A Streptococcus or Strep pyogenes. You have erythrasma, which is caused by Corynebacterium minutissimum. You have erysipeloid, which is caused by Erysipelathrix rhusiopathii. You have impetigo, which can be caused by either Strep pyogenes or Staph aureus. Cellulitis, also Strep pyogenes or Staph aureus. And dermatophytosis, which are caused by your fungi, your dermatophyte fungi, which you will learn more about at the end of the summer. So let's review Erysipelathrix, and there's only one species that's relevant to human infection, and that's Erysipelathrix rhusiopathii. And you guys remember, it's a gram-positive, non-spore-forming, slender, filamentous rod that's pleomorphic. It's facultative to microaerophilic. It grows best in the CO2 incubator. It takes 2 to 3 days to see visible colonies on a plate, and it is alpha hemolytic, so you will see a slight greening of your blood agar plates. So it causes actually erysipeloid. It's a skin inflammation, usually more commonly involved in the fingers and hands, and it causes an erythematous lesion with a raised edge. So individuals that are in close contact with infected animals, especially pigs, such as a veterinarian or a pig farmer, would be more commonly at risk for an erysipeloid infection. So it can lead to septicemia, but that is rare. And in individuals that have septicemia caused by Erysipelathrix, it can cause. This is a ubiquitous organism. It's distributed worldwide, and it is primarily zoonotic. So we already said pigs are the main reservoir. It can be found in other mammals, birds, fish, and soil. Transmission is usually through direct contact of an infected animal, usually through trauma or puncture to the skin, such as getting bitten by an infected animal, and it is more commonly an occupational hazard. So butchers, meat processors, farmers, poultry workers, fish handlers, and veterinarians are going to be at risk. For laboratory diagnosis, it is alpha hemolytic on blood agar. It's non-modal. It's catalase negative. It is positive for hydrogen sulfide production. And that hydrogen sulfide production is a key diagnostic feature of Erysipelathrix because that allows the organism to be differentiated from Listeria and Corynebacterium, which are your two other gram-positive rods. Subcutaneous tissue infections commonly are abscesses, ulcers, or boils, and Staph aureus is the most common agent that causes subcutaneous infections. Remember, abscesses are commonly mixed bacterial infections. So you're going to get a mix of aerobic and anaerobic bacteria in an abscess. So it all depends on the site of an infection. So you might get a mixed facultative aerobic bacterial infection, or you might get an anaerobic infection. So your anaerobic abscesses are more commonly in the perineal inguinal. Meleney's ulcer is a very specific ulcer. It is a chronic, slowly progressive subcutaneous infection. It's commonly caused by streptococcus, but it can be caused by other organisms. Anaerobic cellulitis, when you see this type of infection, you usually will see a lot of gas in the tissues. This is more common in the extremities, in the lower legs, in the arms, and the fingers. It's common in diabetic patients or post-op patients, and usually anaerobic cellulitis is a mixture of both aerobes and anaerobes. So your aerobes commonly found might be E. coli, your alpha or non-hemolytic streptococcus species, and Staphylococcus aureus. Your anaerobes would be Peptostreptococcus, Bacteroides fragilis, Prevotella, Porphyromonas. Your other anaerobic gram-negative rods, and your Clostridium. So remember, you guys saw this slide last semester, your clinically significant anaerobes, and the most clinically significant anaerobe by far is Bacteroides species. Bacteroides causes 43% of all anaerobic infections. Next common would be your anaerobic gram-positive cocci, followed by Propionibacterium, Clostridium, other types of anaerobes such as Prevotella, Porphyromonas, and Fusobacterium. We also have muscle infections. So muscle infections might be necrotizing fasciitis, which is an infection of the fascia, which is overlaying the muscle. So the problem with necrotizing fasciitis is it's an infection that spreads very rapidly and can spread through the entire body. So this is usually caused by group A streptococcus, or it can be caused by Staphylococcus aureus. Also, muscle infections would be gangrene. So chronic gangrenous conditions can occur in post-op infections. Typically, these are mixed infections. Commonly, if you remember, your gangrene is caused by Clostridium perfringens, which is usually the cause of gas gangrene, lots of gas in the tissues. Myositis is muscle infection that can lead to necrosis. Usually this is in individuals that have vascular problems, so they don't have very good blood flow into their extremities, so they get a loss of blood into those areas, which can lead to the death of the muscle tissue. Whenever you have dying tissue, you get necrosis, and you can get secondary bacterial infections. So organisms causing myositis, you have lots of organisms. The most common, I would say, is Clostridium perfringens. For wound infections, you have post-operative wound infections, and these usually are caused by the patient's normal flora that were able to get inside of the body that normally would not have. These are considered nosocomial infections, and the nature of the flora depends on the location of the operation and what type of flora might have been there at the time of operation. If the skin was cleaned well enough, was a contaminated instrument used. So it all depends on the situation, what you might find in a wound infection of a post-op patient. In a individual who has a bite, you can have human bite infections or clenched fist injuries, and you all should be thinking of certain organisms when you hear these things because you know it from last semester. So human bites and clenched fist injuries, you should be thinking Eikenella. Dog bites, you should be thinking Pasteurella. Snake bites, also you can get many different organisms, Eikenella, Pasteurella, several organisms. Burn infections, these are very severe, can lead to bacteremia and significant mortality. So whenever you see burn, you have to think Pseudomonas aeruginosa as well as Providencia. And there are also Staph aureus and other organisms, but definitely Pseudomonas aeruginosa is one of the common burn infection organisms. So your post-op wound organisms. So your normal flora, Staph aureus, coag-negative staph, your enterococcus, you could possibly have strep pyogenes, Proteus, Morganella, Providencia, E. coli, Pseudomonas, Bacteroides, Prevotella porphyromonas, Fusobacterium, and Peptostreptococcus. So if I say an organism and you don't remember anything about that organism, you should go into your textbook, you should be reading your chapters, or you should go back to your notes and go read up on those organisms. Human bite infections, if it's an aerobic infection, it would commonly be your alpha hemolytic strep, Staph aureus, strep pyogenes, or Eikenella carodens. For an anaerobic bite infection, it would be your anaerobic mouth flora, your Peptostreptococcus, Prevotella porphyromonas, or Fusobacterium nucleatum. For animal infections such as dog and cat bites, Pasteurella multocida is going to be your more common one, but you can get a staph species that's common in animals, Staphylococcus intermedius. You can also get Staph aureus, Enterobacter, and Capnocytophaga canemorsus. For snake bites, you can have Pseudomonas, Klebsiella, Proteus, E. coli, Clostridium. So there's several organisms that can be found in snakes. For burn infections, we already said Pseudomonas aeruginosa, Providencia. You can also have Streptococcus, Staph aureus, Staph epidermidis, Enterobacteriaceae members, Pseudomonas, So for a case report, you have a male that's 55 years of age. He previously had a renal transplant. So for a renal transplant, for any organ transplant, individuals are put on immunosuppressive therapy so that they don't reject their organ. So they are highly susceptible to various infections. He's had 5 days of a progressively swollen foot. It began with a very small ulcer that was draining some white fluid. His foot was not painful, and he denied having any type of trauma, so he doesn't recall banging it or cutting it or anything like that. So this patient is a type 2 diabetic with nephropathy. So again, high risk of infection. He has high blood pressure. He claims he doesn't smoke. He doesn't abuse alcohol. He has not had any recent travel, nor has he been exposed to any animals. His medications that he's taking, prednisone, which is going to suppress the immune. He doesn't seem to be in acute distress upon physical examination. His temp is 101.5. His vital signs are stable, but he does have a very swollen right foot that is not tender to the touch, but he has a white drainage of cottage cheese consistency. So here is a picture of the foot. So his foot that's swollen and this ulceration that has been growing and getting bigger with this white ooze of cottage cheese consistency coming out of it. So for his laboratory results, and in the clinical lab, we always have to consider all the results, not just the microbiology results. So His white blood cell count, 14,300, 88% neutrophils. His blood urea nitrogen is 39, creatinine 1.8, and all other lab analyses are within normal range. So what is the differential diagnosis of this patient? You always have to think of the history, you have to think of the risk factors, and this patient has a lot of risk factors. So maybe he has necrotizing fasciitis. That would need to be ruled out, and you should be thinking of those organisms that cause necrotizing fasciitis and what tests would you do to rule those organisms out. Possibly he has chronic osteomyelitis, so a bone infection. He could have Madura foot. We talked about Madura foot last semester. So some of our gram-positive branching rods can cause Madura foot, such as nocardia. Also actinomyces can cause Madura foot. He may have diabetic foot ulcer or crystal arthropathy. So here is the gram stain of that white cottage cheesy discharge coming out of the ulcer. So you can see there are some cells there, some disintegrated white blood cells, some red blood cells, and you do see some organism, but not too many. That would be kind of few gram-positive cocci. So the discharge from the foot was cultured, and on the left you could see the organism, nice golden tannish colored organism, large beta hemolytic. And on the right, this is the organism growing on mannitol salt agar. So if you don't remember what mannitol salt agar is, you should look that up. What does it have in it? What is it testing for? Here is one of the colonies that was growing on the blood agar plate that's gram stained. You see nice gram-positive cocci and clusters. So automatically you should know exactly what organism you're looking at based on the morphology on blood agar, the results on the mannitol salt, and this gram stain. Here is the catalase and coagulase test reaction. So catalase on the left and the coagulase, tube coagulase test on the right. Nice little clot down at the bottom. So you should know if those are positive or negative. And also the cephinase test was positive. So what does that mean? So final diagnosis, automatically you guys should know exactly what this is. And these are the types of questions you would see on a final exam where you're going to get a case, you're going to have various results. There may be some pictures on the final exam that you have to analyze. You should know what those test reactions are and how to interpret them. So the final diagnosis of this patient, he has gout, but he also has a soft tissue superinfection with methicillin-resistant Staphylococcus aureus. So you always have to think of everything, not just micro. So a lot of chemistry analyses in this case study as well. So if you have any questions on wound infections, if you don't recall some of these organisms, some of the test reactions, you need to go back and review those. So in the manual, there are chapters in the textbook that go along with our lectures. So you can go back and read those chapters, and you can go back into your last semester's notes and just read up on some of these organisms if you've forgotten.